Project predicting hospital readmission rate in diabetic patients. Hospitalized patients with diabetes may be at higher risk of readmission than those without diabetes and account for approximately 20.3% of the hospital readmission rate. It is a serious concern for hospitals and health providers as it adds on to the healthcare cost and is a very important metric for healthcare quality measure. Under the Hospital Readmission Reduction Program established by the Patient Protection and Affordable Care Act, Centers for Medicare and Medicaid Services will decrease payments to hospitals that have greater than expected 30-day admission rates. So the goal of the project was to analyze different attributes such as socioeconomic factors, changes in medication, etc., to evaluate associations between these factors and to predict whether the diabetic patient is readmitted or not. The dataset which I used for analysis was from UCI Machine Learning Repository, and it represents 10 years of clinical care at 130 US hospitals and integrated delivery network. The number of attributes were 55 and the number of instances were 1 lakh. Before I show you my data preparation steps, here is the original data, and as you can see here, there are certain IDs like encounter ID, patient number, then followed by some demographic information, then some kind of ID, admission ID, discharge ID. Admission ID refer to if somebody came through emergency, somebody came through referral, that sort of IDs were there. Then finally the diagnosis, the medications, and finally the target variable, which were three variables. First, the patient will not be readmitted. Yes, the patient will be readmitted in greater than 30 days. Yes, the patient will be readmitted in less than 30 days. So coming back to my presentation, I use 9 for my data preparation or data cleaning. I randomized the instances using shuffle node, and then I chose 60,000 instances from the top. The attributes such as encounter ID, patient number, admission type ID were excluded from my analysis, along with weight and pair code, because they had 90% missing values. And the readmitted attribute, instead of using 3 values, I converted them into 2 values, which is readmitted yes, which includes both less than 30 days and greater than 30 days, and readmitted as no. The next step was the attribute selection. Since there were 45 attributes left after I excluded some of the IDs and the attributes with the missing values, I had to find out which attributes will be more useful in the analysis. And based on the ranking, I initially chose the first 25 attributes, and I ignored the other 20 attributes looking at the information gain they were providing. So I just ran my algorithms with first 25 attributes and later on with the first 15 attributes, and I did not find much difference. So I decided that the top 15 attributes are the most informative attributes. My first algorithm was a decision tree, and you can see that the accuracy of the decision tree was 56%, close to 56%, and number of inpatient encounter was the most important attribute, followed by number of diagnoses in predicting whether the patient will be readmitted or not. Second analysis was logistic regression. Again, the accuracy was close to decision tree, and from the coefficients here, it can be concluded again that the number of inpatient encounter is the most important attribute, followed by number of emergency. In case of decision tree, it was number of diagnosis, which is also an important attribute, but according to logistic regression, it is number of emergency, which is the second most important attribute. The third algorithm I used was naive Bayes, and the accuracy for naive Bayes was little higher than the decision tree and logistic regression. And zero, I changed the attributes yes and no as 1 and 0 into the numerical attributes for the naive Bayes and logistic regression. And from the F means, it can be clearly seen that the patients which were not readmitted were more accurately classified than the patients which were readmitted. as F value was closer to 1 in case of patients which were not readmitted. Finally, I did the k-means just to look at the clusters, and I saw I can see here the three clusters. The middle cluster, which is cluster one, seems to be the patients who are at risk of readmission, followed by cluster 2, which is somewhere in between. And when I plotted these clusters against the number of lab procedures, it is clear that the patients who were at most risk were actually higher on with the number of lab procedures, followed by cluster 2, and cluster 0 seems to be the healthier cluster. Finally, I compared my analysis tool, which was 9, with Rapid Minor. There is a tab called Auto Model in Rapid Minor, and I just wanted to compare if there is any differences if I use the same algorithms in both 9 and Rapid Minor. There were not much differences, but yes, naive Bayes was showing more accuracy in 9 in comparison to Rapid Minor. And the other thing with Rapid Minor was I did not excluded any of the attributes, any of the missing values, and any of the instances. So it was using the original data set, which makes me believe that the analysis which I did in 9 was correct, because there was those attributes or those missing values were not giving any um, important information for prediction. Finally, my conclusions were there were not any socioeconomic factors which were contributing to the prediction of readmission, and from k-means clusters, it was visible that the healthier cluster had less number of lab procedure in comparison to the cluster at risk. And finally, from decision tree and logistic regression, number of inpatient encounter was the most important attribute. But my study also had certain limitations. For example, I excluded payer data and weight data, and specifically payer data might be an informational attribute for readmission, but because of the missing values, I did not include it in my analysis. Data did not have an year attribute, so maybe the instances were picked from one particular year, and it might not have given me the best results. And finally, since some of the algorithms will be some of the algorithms might be more robust with more informational attributes such as pair code or other attributes which are not present in the dataset. That's it for my project. Thank you so much.